Hello, good evening to everyone. We're so happy you could be with us for Doc Talk Season 6, Episode 17. Dr. Tennant and Dr. Ibsen have such good things ahead of us, and we have a great guest with us, Andy Boyles. Looking forward to it all. Doc, it's all yours. Please take it away. Thank you.
Thank you very much, Jamie. We do have an excellent program here tonight. Andy Boyles, who has been with me for many, many years, is one of the pioneers in this field, both as an advocate and as a patient, and has had a great success and will give you a lot of tips on how to make a life with this terrible disease. Some of you this week may have seen the bulletin in which we have finally, after many years, developed an alternative to the original inflammatory protocol for adhesive arachnoiditis. And I'm going to come back to that for just a minute. But I wanted to start this session by telling you about some media publicity that I read this week, which is very unfortunate. We still have around the country and around the world, we still have certain media outlets, certain people who keep saying that a disease like adhesive arachnoiditis, and you might as well throw in pudendal neuropathy and CRPS and bone-to-bone arthritis and some of our terrible conditions, that there is no treatment and there is no cure and there's nothing you can do about it, and we don't intend to try to do anything about it. I think that's the message. And unfortunately, that message is still being given out to people by prestigious medical institutions. And what bothers me today is when I see a statement in the media that says there is no treatment for adhesive arachnoiditis. Now, unfortunately, we have a situation in America in which medical semantics rules the day. And we're going to have a little lesson about that because there's some things about it that really are not well understood. And first off, when somebody says there is no treatment, we unfortunately have come in America to a point in time that a treatment is now defined as a labeled pharmaceutical by FDA. Okay? In other words, all those treatments you see on television, they have a specific FDA label targeted that disease. And in the minds now of practitioners and patients, as a treatment means you have a pharmaceutical, not a surgery, not a physical therapy, not a mental health attribute, no diet. Those are not treatments today. A treatment today in America is defined as a pharmaceutical treatment labeled by FDA, and anything other than that is not considered treatment. I don't know what it's considered. Let's call it therapeutics if you want. In fact, that's not a bad term, either therapeutic measurements. But when you hear the term treatment, that's what people are referring to today. And unfortunately, the insurance companies have bought into this. And therefore, they use that term treatment. If there's not a labeled pharmaceutical for that disease, in other words, they're sort of, and a lot of them are saying, we don't have to pay for it. It's not a labeled treatment. Well, they don't label physical therapies for diseases. They don't label diets. They don't label nutraceuticals or natural products. Those are not considered treatments today. So we have this terrible situation that if you don't have a single pharmaceutical with an FDA label, that's not considered a treatment today in today's fouled up medical system. Okay, so that's the first thing you need to know. Now, that's the bad news. Now, let me tell you the good news. Some years ago, in fact, I actually think it came out of the nurse practitioner and the PA movement, is that doctors would devise a flow chart that became known as a protocol for nurse practitioners and physician assistants to work under them. And that's where the name protocol really emerged. But then it broadened out a little bit in a very positive way. And so today, sophisticated physicians are well aware of the term protocol. And what does that mean? A protocol means that you don't have a specific FDA targeted treatment. you have a system. In other words, you have multiple therapeutic agents or measures that you throw in the hopper and you apply them simultaneously, knowing that if one doesn't work, another one works. Now, this is not just being done in chronic pain management. This is being done in cardiology, pulmonology, gastroenterology. In other words, if you have a chronic disease, and if you go to your doctor and if they only give you one thing, that's not very good medical practice today. Your better medical practitioners know to give you more than one thing at a time, because if this one doesn't get you, this one will. Sort of like a football team. If the tight end doesn't get you, maybe the tackle will. Okay? So think of it that way. You got a team of therapeutic agents, of which one doesn't get you, the other one will. And so we've been at this in pain management much longer than what anybody realizes. I actually started my pain practice in, believe it or not, 1776, right after the Vietnam War. And in those days, we were as part of the public health service. And in those days, everybody encouraged us, from DEA to FDA to the local sheriff. Everybody wanted treatment back in those days. So I've been through the days when we didn't have this division of influence and controversy. But even clear back then, we realized something. When we saw a pain patient, literally in 1976, we knew one thing. The first thing you might not know what's causing the pain. We may know it's in the back or the hip or the head or the shoulder or the chest. It may be somewhere. And we may not have known exactly the cause in those days because we'd never heard of fibromyalgia then, or arachnoiditis, or CRPS, or pudendal neuropathy, or bone-on-bone arthritis. Those terms were not used in those days. We did use such terms as post-polio pain, however, and neuropathies, and even those were present back in those days. But at any rate, we knew one thing. If we didn't do step one, get the pain under control, you couldn't walk, you couldn't think, you couldn't even think about the possibility of doing diagnostic tests and treating the underlying cause. And so one thing has not changed since 1976, and that is, when it comes to chronic pain management, step one is pain relief. Okay? Now, why do I bring this up? I continually get correspondence in which people are trying to relieve their pain without pain relievers. Okay? Now let me say this again. They think they're trying to relieve their pain with what I call non-pain relievers that sometimes give you pain relief, but they're not true pain relievers. This includes the peptides, the hormones, the anti-inflammatories, the steroids. These are not pain relievers, but they give you some pain relief indirectly. They're not direct pain relievers. And so I'm going to be asking Dr. Ibsen and Dr. Guess, or maybe even Andy here later, about direct pain relief. And that means direct pain relief usually means an opioid drug. There are a few other direct pain relievers like oxytocin, the hormone, and ketamine. Those are direct pain relievers, but they're few and far between. So what I want to try to make a point of tonight, and I know it sounds maybe too simplistic, a person with these painful conditions, step one has got to have direct pain relievers, not BPC 157 or ivermectin. Those are indirect pain relievers. You got to have hydrocodone. You got to have oxycodone. You got to have tramadol, codeine. You got to have something that relieves pain. And I continually get correspondence literally every other day from somebody who says they've got terrible pain relief. And I ask, well, what are you taking for pain? Oh, well, I'm taking methylprednisolone. Well, that's an indirect pain reliever. That's not a pain reliever. So tonight, what I want to focus on is something I almost hate to bring up: direct pain relief. Everybody who's got a chronic pain condition has got to have in their medicine cabinet, they better have an opioid, and if not an opioid, they better have ketamine or oxytocin. Those are the only two other direct pain relievers I know besides opioids. Okay? And I want to talk more about that because I also think that our effort to get medical boards to work with us, they're doing better than we think when it comes to the weaker opioids. And so And I also find that patients are not going to doctors asking for low potency opioids. So that's one of my big messages today. But to go further, I want to talk about not just protocol, but I want to talk about another concept in chronic pain management that's not appreciated. It's really steps 1, 2, and 3. And you've heard me over the time that we've been here talk about the three components of treatment. Number 1, suppression of inflammation and autoimmunity. Number 2, regeneration of nerve tissue, and particularly the cauda equina and the arachnoid membrane, or their long nerves, or your glial cells. And number 4, you've got to have pain relief. But actually, step 1 is pain relief. Number 2 is suppression of inflammation and autoimmunity. Then number 3, you try to regenerate the tissues. It's steps 1, 2, and 3. But there's another aspect of this that I want to call to your attention, and that is treatment really is in phases 1 and 2. Okay, now here's what I'm getting at. Phase 1 is what I call stabilization. This is when you know you've just been given the diagnosis of adhesive arachnoiditis, you've just had an EMG, and you've been told you got CRPS. The rheumatologist or the orthopedist has said you got bone-on-bone arthritis. The minute you get your diagnosis, the first thing you got to try to do is get some pain relief and get what I call stabilization. Now, what does stabilization mean, and why is it important? Stabilization means that you've got something on your medicine cabinet, in your medicine cabinet, that you can take and get pain relief within 1 hour. That's an essential, okay? But also a stabilization means that you've got enough relief to function. You can take care of yourself. You can dress yourself. You can eat. Maybe you can drive a car, keep your job, take care of the family. In other words, you can do what we like to call activities of daily living, okay? And can you walk? Big key. Can you walk without a cane or a walker? So if you can get your immediate pain relief and you can walk and you can do your activities of daily living, you have stabilized, okay? Now, why is this important? Stabilization usually means you've got to have a pain reliever and some anti-inflammatory action. So you're going to have multiple things right there. But once you get stabilization, then you want to go to what I call phase 2. That's regeneration. And I'm here to tell you that phase 2 is when you go for some cure. I didn't say the cure, I said curative, meaning permanent reduction of your pain and some of your symptoms. Those are what we call curative measures. May not get you cured, but it gets you permanently better. Now we're getting a lot of great things coming on board to help regenerate tissues. You're going to see a lot coming out about regenerative hormones in the next few weeks, and we're getting new things. And I do want to call to your attention that there's a new peptide out that I'm high on, and for regeneration, and it's ILL37. It's called thymosin alpha 1LL-37. That combines thymosin and a new peptide called ILL37. I'm very high on this for regeneration, and I bring it up because that's part of the regeneration of your cauda equina and your arachnoid membrane. So remember, let me summarize here and then move on here with our interview here today. And a couple of that, I do want to mention the new protocol for a minute. So a treatment usually means a pharmaceutical labeled drug. And there is no pharmaceutical labeled drug for none of the severe pain conditions that are in America today. You treat this with a protocol, and the protocol is multiple therapeutic measures at one time to get the job done. And your sophisticated doctors and nurse practitioners know how to use protocols today. And then thirdly, the first step in dealing with a chronic pain condition is you've got to have direct pain relief, not indirect, but direct pain relief. And only the opioids and maybe ketamine and oxytocin are direct pain relievers. We have a very small menu, and you've got to do that. Now, some of your neuropathic agents also are in that category. Gabapentin, Lyrica, Valium, some of those are direct pain relievers. But you've got to have direct pain relief. Step 1 in treating these conditions. I'd like to say a couple of words now about the new protocol. We started off treating adhesive arachnoiditis 8 years ago. The two drugs that emerged that were effective were methylprednisolone and Toradol. And so the standard anti-inflammatory protocol for many years has been low-dose methylprednisolone and ketorolac. And they've served us very well. Millions of people have been able to use this combination and get better. The problem we have with it is that these two drugs raise red flags in the eyes of every doctor, including me. I hated it when I found out they were the only two things that seemed to work for adhesive arachnoiditis. Why? Your corticosteroids and ketorolac both have a lot of complications, and the doctors know this. And some, they just simply don't want to take the risk of prescribing them. Some work for institutions that ban these drugs and won't let them prescribe these drugs. Sometimes insurance companies won't pay for them. But also, there's another element to this that patients don't think about. When a doctor prescribes a drug with a lot of known complications, he or she is obligated to monitor that patient with extra tests and time, and the doctor simply may not want to give it. The bottom line is this: we have increasingly learned that around the world, ranging from Europe and Asia, South America, Australia, America, that doctors don't want to use ketorolac or methylprednisolone. And so through trial and error, we have an alternative to the use of low-dose methylprednisolone and ketorolac. That doesn't mean you want to stop your methylprednisolone or ketorolac, or the doctors don't want to quit using them, but we do now have an alternative. It's in our latest bulletin, and it comprises of three different medicinals: pregnenolone, palmatory ethanolamide with Lodiola, known as PEA, and glutathione. And those three in combination do equal the anti-inflammatory effects of the other two. And in fact, they also have a lot of regenerative capabilities. The downside of the new protocol is that it doesn't have the pain relieving effect of ketorolac. Okay? Ketorolac is just hard to beat for relieving pain when you have a flare of adhesive arachnoiditis. You can actually mix the two protocols, but at this time we now have something that physicians and nurse practitioners or even patients themselves can start on this new protocol. And frankly, in the long run, it's a better protocol. It's safer and it's more regenerative. And so we're quite high on it, but we're trying to give practitioners around the world a choice in protocols. So this next year, we hope to have multiple choices that mental patients and practitioners can both use. With that, I want to call on our guest tonight, Andy Boyles. Can you bring Andy in, Jamie?
Yes, sir. Welcome, Andy. Thank you for being here with us.
Can you hear me okay?
Yes,
Andy,
sir.
how you doing?
Hey, Dr. Tennant.
Good.
Doing okay. Thank you.
You're still in Canada.
No, we're actually here in Las Vegas now.
Oh, you're back in Vegas where I can come visit you.
Yes, you can.
So
Anytime you want. Yes.
let me just give a quick introduction, then I'm going to ask you to tell about yourself. Andy and I have been working together for quite a number of years now. He was one of the first people that I encountered with this disease. He's one of the people who figured out how to tackle the disease and do something about it. And he's had quite a career himself, was an excellent businessman. And he's also a good friend of mine and been an advisor to me for quite some time. Andy, start off a little bit. I'd like for people to know who you are, where you came from, what you did for a living. Start at ground zero. Where were you born? Where were you raised? I want people to know your background. And also, I want people to know that men like you have been immensely successful in your own careers, and this disease hits anybody.
Okay. Well, I was born in Canada, in New Brunswick, Canada,
Very
1964. And I got involved in sports in my early years. My grandfather was an athlete himself, and he got me into sports. And I got into rowing, competitive rowing, my early years. And I was thinking about this, I've thought about this many times, but I can trace back to when I had my first injury with my back to being involved with competitive rowing when I was 16 years old. And I remember having about 6 months of my life where I had hurt my back and I could barely lift anything more than about 5 pounds for about 6 months. And in retrospect, I've thought about that a lot. And it's like, well, that's the first time I probably injured a disc in my back, and that was the beginning of everything that was to come after that. But I got out of competitive athletics when I was in my early 20s when I went to university. I got an engineering degree, a degree in math and computer science, and I spent my career as a systems engineer doing design work for telecommunications, and then as a manager of engineers and designers, and also as a finished my career after 27 years and spent half of my career as an executive in the company as well. But I did have through my life, and especially even early in my work life, I've had some pretty serious problems with my back. Um, In 1992, I injured my back working out at a gym at work, and it eventually led to a laminectomy, discectomy surgery the following year in May of 1993. The neurosurgeon that did the surgery on me told me that he spent almost 3 hours picking the disc fragments off of my spine. And he said it was a very difficult operation. And I had an awfully hard time recovering from that. Most people at that time said, "Oh, you'll be back to normal." And within 6 months, I wasn't. A year later, I still wasn't. And then many years later, sort of fast forwarding to within the last few years, my wife and I happened to be looking through some old boxes of papers in our garage and came across the surgical notes of my initial surgery and read that the doctor had admitted to, uh, unfortunately, slicing through my arachnoid layer. And it was, uh, it just made everything clear to me why I've had so much trouble for so many years. So that surgery led to mostly a recovery for quite a few years. But then, yes, it would have been 20 years later, and the disc that was below that disc, so that was at L4, L5 was the one that went. The L5S1 disc went. I had another surgery, and it didn't go very well at all. And um, it actually, I think, was the catalyst for the the discs in the bottom of my lumbar spine just collapsing, which they eventually did. So I had the surgery in January of 2013. By 2016, I was in pretty terrible pain. I didn't know what it was, but I ended up going to Germany to get a 5 level disc replacement. I had the bottom 3 levels of my lumbar spine, the discs replaced, so L2 through S1. And then in my neck, I also had two replaced in my neck as well, C4 through C6. A lot of good results from that surgery for most people. And I did great with my neck, but I was still having issues in my lumbar spine. And by about the fall of 2017, which was about 10 months after I had that surgery, I was getting pretty desperate trying to figure out what was going on with me. And I can remember the day that I found the Arachnoiditis Hope site because I was doing a lot of Google searches trying to figure out why I was having all these different symptoms. And it didn't seem to fit with the surgery, the results of what the surgery should have done for me. And anyway, I found your site and I went through the self-diagnosis, and through that process, I diagnosed myself as a, geez, I think I've got adhesive arachnoiditis. So um, had joined, my wife and I joined a Facebook group in Canada, um, that there was some people that were talking about this condition, and one of them knew how to get in touch with you, Dr. Tennant. Her name was Louise Carbonneau, and she was able to get through to you and ask you if you could please have a look at my uh, radiology, my diagnostic imaging. And from that point, I think it was we first met each other. It would have been like 8 years ago this week. My wife Lisa and I came down to see you at your clinic, and it was a huge change in my life because at that point in time, I thought there wasn't really any hope of ever getting better. I mean, I was pretty seriously depressed and thought that things just could never get better. And I can remember you spending a few hours with us in your clinic in West Covina and saying that, if you follow this protocol, you have a pretty good chance of getting better within about 5 years. And, it's after within about 5 to 6 years, I had significantly improved by following your protocol. Plus, I also added one thing, and this would have been back in just 5 years ago, about 5.5 years ago. My I was lucky enough to have a personal physician in Canada who believed in your protocol because he was very honest. He said, "We have nothing to offer you here, but if you feel that this is a good chance for you to get better, then I'll support you with this." So he's my doctor. I have to give him credit back in Canada. He's done everything that he can to follow your protocol and your advice for all these years. And that's been over 8 years now. But he prescribed me a fentanyl patch, and the addition of the fentanyl to the protocol made a huge difference for me. And I've been on that fentanyl patch now. It's a 50 microgram per hour dosage, and it's a 3-day patch. It's been 5.5 years, and it has turned my life around quite a bit. So I'll just stop there, Dr. Tennant. I don't know if there's anything that you'd want to say at this point, but
Well, a couple of things. I happen to know that besides your medications and protocol, you've been very active physically. Would you like to tell us a little bit about your own physical program? I've been impressed that that's one of the things that's kept you going.
yeah, I have tried to do my best to keep as active as I possibly can, because that's one of the things that's part of your protocol was that you have to keep active, moving. Um, so I've been doing my best to. I started off trying to walk about 6,000 steps a day, and I was doing pretty well with that for a few years, from say 2018 through to 2022 or 2023. But I found that if I pushed myself to do that every day, it was it was getting to a point where it wasn't helping me. It was kind of setting me backwards. So I've kind of evolved to a point of where I do as much activity as I can every day, but I also balance that off with I also want to feel good too. I don't I'd like to have, a fairly minimal amount of pain, which I mostly do most days. So I've been able to find the balance between being active as much as I can, and also not not doing it so much that it creates too much pain. And I think it's taken me many years to figure this out. I mean, it's a very difficult disease to try to figure out, in your head about why you feel a certain way some days and why you're okay some days, why other days you're not. It's pretty complex. I mean, I'm not a doctor, so for me, it's been difficult to try to sort through it, but I'm, I'm much better than I was, say 8 years ago. And I think my wife would testify to that as well, is that she said, it took a long time, but gradually, you eventually got better. And that is true. So we we live in Canada, the eastern part of Canada. It's right out on the Atlantic Ocean in Nova Scotia. It's a long trip to come down to Las Vegas. Like it's a 6 hour flight to go from Halifax to Calgary, and then from Calgary to Las Vegas, it's another 3 hours. So it's like a 15 or 16 hour day of traveling for us. And I find that still is tough, um, but we do it um, every year, a couple of times a year, and we still enjoy traveling around here and walking. And um, so it's been, I guess I'll say that I haven't had to shut my life down by any means. Um, it's gradually gotten better over time.
Do you feel you're continuing to get better?
I think that I'm at a point where I'm sort of holding my own. Like I would say that like I couldn't say that I'm able to walk more than I used to. I'm probably doing a bit less, but I'm also like I said, balancing that with making sure that I feel I cause myself less pain by not not pushing it too much. So it's a balancing act. But life is still good for me. Um, I still enjoy life. We still go out and do things, and so that's all positive.
Yeah. What do you do now to have a quality of life? I know you're very active doing a lot of things, including this new ham operator thing you're into.
Oh
And
yeah,
what,
yeah,
tell
yeah,
me about, you've been a guy who you haven't let this disease slow you down from being involved in life. I'd like to hear about that.
yeah.
Okay.
No, that's very true. I mean, my wife and I used to go out and walk, 20, 25 kilometers a day, which is about 15 miles a day many years ago before this really set in. But we still go out. What we do is we go out every day and walk a couple of times, maybe like a mile walk a couple of times a day, sometimes 3 times a day. Um, we uh, and as you mentioned, like I've also felt that I've had to keep my brain active as well. It's not just my body, but also my mind. So having been an engineer for a lot of years, I find that I need things to stimulate my mind and to keep it active. And as you mentioned, I got into amateur radio last year, sort of re-educating myself on physics and electric circuits and how radio waves work and that type of thing. And um, another thing that my wife and I do while we're down here in Las Vegas is we visit um, a corral where we go out and see horses and mules, at least once a week for a few hours, spend some time outside. And that's one thing that we tend to do a lot is try to get outside in the fresh air as much as we can, go to local parks, um, take a book, read. Um, those are the types of things that I've done to try to keep myself active.
Yeah. Next question. How many, you described them, how many separate surgeries have you had?
Yeah, I had my first surgery in 1993. It was a laminectomy discectomy at L5S1. Um, my second surgery was in January of 2013, so almost 20 years later. And that was laminectomy discectomy at L5S1. And then I had a major surgery, like the most major surgery that I had in Germany in January of 2017, which was 9 years ago, just a couple of days ago. It was January 12th of 2017, and that was an artificial disc replacement of the bottom three discs in my lumbar spine, so L2 through to S1. and 2 discs in my cervical spine from C4 to C6. So C4, C5, and C5, C6. Those are the three surgeries that I've had.
Hey, well, what I've got some other questions I want to ask you, but frankly, you should be an inspiration to all the army of people out here who have had these multiple spine surgeries. It's so demoralizing and humiliating, and people give up, but you didn't. And so I want to back up a little bit here, and let's go back to when you and I first started. I frankly don't remember what we did to start with, but you've obviously did something else that I really want to admonish people about, and that is you kept building your program over time. You didn't just stop. You kept adding things and doing things. Can
Yes.
you go clear back to the beginning? How did we start out in medicine? What'd you add? What'd you subtract? Diet, supplements? Give us a little idea on your building blocks as you went along the way, including your mental blocks on what you did to come to this point. I mean, frankly, Andy, you're at an age, how old are you now?
61.
61. Most people who have had this disease historically have died before age 60. In the old days, you didn't live very long with this disease, particularly if you'd had all the surgeries you had and all the trauma. But what you've done, whether you've thought, I wanted you to think about this now. I wanted to trap you here on the program before you had a chance to think about it.
Okay.
The concept of building a program and to keep building it, okay? Don't just expect the doctor to give you something today and that's it, but to keep building and keep working on building your body and your mind, which you've done, and now you're in your 60s and you still got a life. And so that's what I wanted you to tell us a little more about, okay?
Okay, sure. Um, well, I guess as far as the program goes of treatment, um, I had my surgeries, and then there was really no real treatment until you and I connected, because there was in Canada and in the U.S., because I had seen other people in the U.S. many years ago. There was really nothing to offer. It was, well, it's surgery. I hope it works out. If it doesn't work out, I'm sorry. Um, and then even my doctor in Canada, and I was lucky that I also had another doctor that was working at the company that I worked for, that was also helping me out. They suggested that I go to Johns Hopkins to find out what they could do for me, and to diagnose what was wrong. So my wife and I traveled there in November of 2017, and it wasn't a good experience. They did some tests on me, like a CT scan with a myelogram, and basically said that the only thing that could be done to help you is to get a spinal cord stimulator. And I think at the time they were quoting that it would probably cost about $150,000. Um, my wife and I had done a bunch of reading on the internet, and even at that point, we had concluded that that wasn't going to happen. It didn't make any sense, and it was in its infancy, and I wasn't going to be a guinea pig for another surgery. So we basically said, no, I don't think so. And then we were able to get through to you, and we started on the protocol. And to this day, I mean, the things that have, as you mentioned earlier, the things that have really helped me has been the ketorolac, Retoradol, methylprednisolone. Um, the I've added the PEA and the luteolin. Um, the what? Oh yeah, serapeptase. Um, I've added the BPC 157 within the last couple of years. And of course, I added uh, the fentanyl patch back in 2020. HCG, I'm still on HCG for nerve regeneration. Um, and I can remember you telling me that this isn't going to be something that you're going to be able to do for 3 months. and expect results. You said that you've got to stick with this for years. And so I have. I mean, it's just, I take a lot of supplements and a lot of medications, but it's made a big difference. I mean, I don't do a lot of reading myself on what other people are going through with arachnoiditis because the mental aspect of dealing with it is not easy, and I find some of those stories can kind of drag you down a little bit. But my wife does the reading on those, and she tells me that relatively speaking, compared to what I've been through versus what a lot of other people have gone through, is that I'm doing quite a bit better. Um, and I think it's just a combination of having been lucky enough to meet up with you and for to get your help and to persevere as well, not to give up and to be determined to still be able to live, a life that's worthwhile. And the support from my wife, because I think family support is huge. So it's all of those things.
Yeah, you've really put it together. And I'm going to ask Dr. Ibsen and Dr. Guest if they've got some questions. But I would have one other thing. To a new patient who just got diagnosed with this, what's your first advice?
Well, I would make sure that they start on your protocol right away and have a talk with their doctor and try to convince their doctor that what you're recommending has been working for a lot of people. Because at the end of the day, their personal physician has to be the conduit through which they get their medications and support. I was very lucky with that. I have to say that we in Canada we are fortunate that we haven't yet turned medicine into a political issue. So, if when my doctor and my two physicians up there, my personal physicians, realized what I had after having, looked at your literature and your recommendations, they had no problem at all recommending me to be on an opioid. No problem. Um, there's only so much of a dosage that can be prescribed on a daily basis, but it wasn't like they didn't have the attitude that, oh well, this is a bad thing to be on. That quite the contrary. There's only so much that their own medical society will allow them to prescribe on a daily basis. So
Very good. Um, Dr. Ibsen, Dr. Guest, what do you got for Andy?
I'm just a Canadian medicine at this point. I'm amazed that you got an opioid, especially fentanyl, in this day and age. That would never happen down here south of the border for us. They've just gone nuts. The exercise thing, I can't emphasize that enough. I always, when I was working with Dr. Tennant, I mean, people who were completely bedbound or chairbound, I always told them to start off. This is just walk to the mailbox and back, or just down to the sidewalk and back.
yep.
Do it every day, and after a while, it won't wear you out, and then you can go to the house next door and back. And it's the perseverance, and just because it doesn't cost any money to walk. You don't have to you don't have to join a gym. It's right out your front door, and you can just tailor it to what you can do so well by going just one house at a time. And in maybe a month's time, next thing you know, you're going around the block, and then you're going around the block twice. So thank you for bringing up how much exercise and as simple as walking is such a benefit.
Yeah, and I totally agree with that. And another thing too is not to allow yourself to get too disappointed if you go out and do some exercise and you have a bad day the next day. It's just chalk it up to, what, that's just going to happen at times.
Oh
And
yeah,
it doesn't that you should stop going out for a walk the next day. Every day is sort of a different day. And the trick for me is to try to find the balance of where I knew that if I went farther than a certain point, I was going to be in trouble, and to try to just not quite go there.
exactly. Because When we were in college and high school, our coaches always said, no pain, no gain. And that's in the past because right now you just you have to go right up to that edge, but not go over it because at this point and with condition like this, pain is damage. And so we just need to
Right.
keep that exercise level right on the edge, but don't cross over that line of pain because now you're causing inflammation and aggravating the condition. So just right up to the edge, but
Yeah. Oh, exactly.
perseverance.
Stop at the
The
edge. I
most
don't know how to do that. Do you have a seminar for that?
That was it. That was the mini seminar. Walk to the mailbox once a day.
Andy, you're so inspiring in your story. Cora commented here about, do you ever have a day where you just want to burst out in tears? And um, and the tears that we experience, the sometimes they're about miracles and joy and relief and safety. And you come on this conversation that we have with everybody in the similar tribe, and you suddenly feel safe and you want to weep. It's sort of like how a child falls, scrapes their knee, and they don't cry till they get back to mama's lap. And this group is mama's lap for many of us, where we can feel safe to tell the truth about how we've done. And yes, we've been cursed with illnesses. And the only thing you can do when you've been dealt some bad cards is discard as many of those bad cards as you can, and then go to the deck and pick out some new ones. And everybody that's here has been doing that. I'd like to acknowledge you, Scott, because your backdrop is very inspiring with a bicycle and a guitar behind it. So not only exercise, but also self-expression. Um,
And keeping the brain sharp.
yeah, yeah, yeah. Well, first you got to get it sharp. I'll catch up to you, and then maybe keep up. But it seems to me that um, there's two ways you can handle a chronic illness like this. One is give up, and there are many who've given up. They're just not here.
Yeah.
And those of us that are here are not giving up, and that includes your doctors and your family members that know that what you need is self-care, self-care, self-care. That's all. Thank
Well,
you.
yeah, I guess what I'd say to that is, yes, I've had many, 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 many days where I've been in tears and not even really believing that I was going to get better. That was quite a few years, you know. So, but gradually, as I followed the protocol and I went through a lot of flares, like I've been through so many flares. Um, gradually over time, it was there was more time in between my flares, and that was a sign of progress. And I was, having like probably like a major flare every 10 weeks to 3 months, like a major flare. It would take me a month to 6 weeks to get over it. Um, it's been quite a while since I've had something like that. And to me, that's a lot of progress too. And it is the result of trying to figure out what is best for me and what I can handle, what I can't handle. And I also believe that it's a sign that the protocol, the approach, and the not giving up and the perseverance is also working too.
What were you, if I may ask, what are you using for flares?
Uh, you know, I used to use methylprednisolone, the 6-5-4-3-2-1
Hmm.
approach. But now I don't think I think my flares don't last nearly as long as they used to. So now if I have a flare, I basically just back off on activity for a while, just give myself a break and say, you know what, for the next 2 or 3 days, I'm just going to take it easy and see how this thing goes. And that seems to be uh, what I'm able to handle it with now versus years ago. It would be there's no way I could, that would just wouldn't happen. I would be, doing the methylprednisolone extra treatment and maybe an extra shot of ketorolac, but not so much now. And I think that's part of the reason is that Dr. Tennant mentioned earlier is some of the anti-inflammatories that he's recommending to replace ketorolac and methylprednisolone. I've already layered that in for the last few years on top of it.
Okay.
So, yeah. Now, one thing that I did find that I had to be very careful of was the ketorolac is brutal on your kidneys. And I was on a dose of, I think it was 90 milligrams a week for about 6.5 years. And I lost probably about 20 to 25% of my kidney function. And my doctor in Canada said, you've got to get off of it. That was back in May of 2024. So it's not over a year and a half ago. And Dr. Tennant and I have talked back and forth about how I was doing when I was off of the ketorolac. And I was okay for a few months, but not so much afterward. I felt that I needed to be on even just a little bit of it. And I've got my dosage down from 90 milligrams a week to 1 milligram a day or 30 milligrams a month. And even that small amount. And what I do is I take a shot of 5 milligrams every 5 days, not a great big shot at once. So we space it out so that the body doesn't have to deal with that much of the drug at one time. And it seems to be working. So I'm down by probably 80% compared to where I was on the ketorolac and still managing to do pretty well.
Andy, a couple of things. We've had some questions flash up here on the screen. One is, what is your Epstein-Barr viral results? I forget what they are. I know I've seen them.
Right. Yeah, I forget what they are too. But what I know is they were pretty high. And I had
I don't think you had reactivation.
I think I was in the reactivation territory for sure. When I got the testing done, based on your advice, when I got the testing done, I was definitely in reactivation. So I started with like the 2,000 milligrams of vitamin C every day, monolaurin, and selenium. And I can't be on the monolaurin all the time. It's sort of like I'm on it for a month, I'm off it for a month. But the selenium and the vitamin C, I'm on it every day. And I will say that, and I started that, it would have been around April to May of last year. And I don't know if it was a coincidence, but I had like the best summer physically, active wise, that I've had in many years this past summer. And I thought, well, maybe it was the EBV treatment that helped reduce, the amount of inflammation in my body. Maybe that's what helped. I don't really know. I'm going to get it retested this spring. You basically can't get it tested in Canada under public medicine. They just won't do it. But I can pay for it down here, and I'll get that done pretty soon.
Good. Couple of things. With the protocol you're on, your luteolin, your BPCs, you're doing a lot of stuff to keep that virus suppressed. And that's part of your success, I'm sure. A lot of people, we haven't emphasized it enough, but the new protocols and the new things you're doing keep the virus at bay. In other words, just because you've got a reactivated virus, that we've got the tools to keep that virus submerged and keep it out of harm's way. You bet. Another thing, too, which has just been brought up, somebody has said they'd like to have a copy of your protocol. Now, you wrote me a story one time about yourself, but again, Amphi, I can't impress upon you enough that we need to get down what you're doing in writing, because yours should be an inspiration to all the people who have had all these surgeries. Okay? I mean, you've managed to make it with that in many ways. So again, we thank you. Now, I have one last question, and I also want to address this same question to Scott and to Mark. The system has come down to where patients are going to do what you did. They end up getting a diagnosis of adhesive arachnoiditis, and the only resource they have really is to go to their own local doctor and ask for help. And we need to figure out how to help people go to their doctors and at least get some low potency opioids and at least get started. And I'd like your thoughts on how do we enhance this interchange between the patient, the newly diagnosed case, and the person who needs opioids. Okay? And I see Norm Clemens out there who, if you turned him loose, we wouldn't have any problems. He's
Yeah.
our secret weapon. But
Oh,
anyway, we
thank
need
you.
to, we're going to have to depend on local doctors to at least get them started with low dose opioids, the less potent ones. And I don't think the medical boards will have any problem with that either. So anyway, to close us out, any last comments on how does a patient go to their local doctor and get started with some pain relief?
Don't start off with Norco and Percocet. We've got some nice low dose opioids out there. We've got tramadol, and too many people forget about because it's old farts. We know about it. Tylenol with codeine, 30 milligram, 60 milligram. It's still out there. That's a fine place to start. And I'm
Let
sorry
me
I interrupted, Norm. Go ahead.
let me ask you the right question. My greatest fear for
Norm,
Andy is
we're running out of time, but let's hear your
okay.
comments. We haven't heard
Well,
from you for
my,
a while. You've been
okay,
hiding out
yeah.
again,
My greatest
probably
fear for Andy,
justifiably. But give us the
yeah,
final word on today, would you?
my greatest fear for Andy is he's come to the United States. I was just kind of wondering what the question is: has he, when he was in Canada, did he run into the, I call him the PharmD physician wannabe that wanted to stop him from getting his fentanyl patches and those sort of? Has he encountered that here in the United States, or and did he encounter that in Canada? So that's
Well, uh, yeah, I can answer that for sure. I haven't gone to any like personal physicians here in the US. I just I just rely on my personal physicians in Canada, and Dr. Tennant. So no, I haven't been refused fentanyl. My wife is making some movements here, like to say that that's not the case. That maybe it isn't, but when I had my personal physician, and I've had him for over 20 years, and my doctor that used to work with me at work, he was one of the officers of the company. He's the chief medical officer. They understood what I was up against. They knew my history, and they had no issue with prescribing it. The issue that they had was with the Nova Scotia Medical Society and
oh,
their
back.
guidelines about how much could be prescribed per day, and so that's an issue. I think that's always an issue for doctors. The medical societies seem to be like a nemesis for the doctors for some reason or other. They don't seem to be as much of a support. But anyway, that's just my perspective.
Thank you very much.
Um, no, I'm done.
Again, thank you, Norm. And incidentally, Norm, while I've got you here, I have loved this stuff you've been writing. It's been making my day. God love you.
Thank you.
I never realized you were that smart.
Oh man, I got an
And
article
you're a
coming
good
out
writer
right
too.
now.
You
I
keep it
it's
up.
an
You
art.
hear me?
I'm writing an
Don't be
article
letting
right
anything
now.
down. Okay.
I wrote an
All
article
right.
right now
Jamie,
called the
we're
10
going to have to
protocols.
put a wrap around these rebels here today. And I want to thank you, Andy, so terribly much. Mark, Scott, Norm, Jamie, it's been a great session. And I hope everybody's learned a lot. And we're going to carry on with this theme next week. Thank you and good night.
Thank
Thank
you.
you.
Thank you all. And good night to all
Pleasure.
of
Thank
you.
you.
If anybody would like to say good night and goodbye, here's your chance.
We keep reading it. We put some really powerful articles out there about the state boards and the California State Board and really addressing their incompetence. And I heard from Dr. Nabran Dasgupta he was extremely happy about the article that we wrote about him concerning the morphine milligram equivalent. He says, get it out there. And the one called, there's one we just published called the Rise of the Prosecutorial Psychopath. I even
Yes.
got a copy on that one.
Yes.
And also, I'm writing as we speak. I'm finishing up the article called The Tennant Protocols. So
Excellent.
continue to read and support. You are
Yes.
within the norms.com. We can use a few donations here and there because, boy, these guys are doing all they can to wipe me out of here. To
Right.
wipe and to wipe
That's right.
this
That's
entire,
right.
right. I mean,
That's
they are
right.
doing overtime.
Yes. And Doc
Yeah.
Norm, you're not fighting alone. You know that. We're with you, and
Well,
we
thank you.
appreciate everything you do. I really loved the article you did on Dr. Lawhern's topics. That was
Oh,
excellent.
well,
All of your articles have been
well, no,
phenomenal. So thank you so
and
much.
so don't give me no. It just was. I developed that sign CLOP that dealt with the Curtis Lawhern protocols,
Yes, sir.
and also the phrase we work with Dr. Gupta and getting the Gupta morphine flawed factors is another phrase that we come up with, and those sort of
Yes,
things.
sir.
So we're going to keep them keep keep it going because I mean it's not just we're running into a lot of all of us have been exposed to a lot of ignorance and a lot of just outright stupidity. And
Yes.
also, some people need to know one more. There's a thing called I don't know if people are aware of a thing called the Mallinckrodt list. Have you ever heard of that? Well,
I
they
don't
got a
believe so.
special list called a Mallinckrodt list that the DEA has forced Mallinckrodt to do, and you're just put on this list. And once you're on that list, you can't get the practitioner cannot order any any type of control anywhere. And Mallinckrodt controls the list, and all the suppliers are supposed to send this list, their name into this list. I had two pharmacies that I encountered. Guys I knew had been in business for 20 some years were completely shut down because of a thing called the Mallinckrodt list. So we're looking into that. And I
Okay,
found out
good.
about that
Thank you
yesterday.
for that. Wow.
Yeah.
Thank you for that. You seem to cover every topic there is. Like you said, you
Yeah.
leave no stone unturned, and I appreciate what you do. We are out of time, unfortunately, but we will see you again next week. We have a great show already planned for next week, so we hope everybody can make it. It's super exciting. Andy, you did a phenomenal job. Thank you for your
Thank you,
inspiration.
Andy.
You've just been a breath of fresh air to me and all the
Thank
others
you,
I
Andy.
know. So
Janie,
thank
Yeah.
you.
remember, it's
Thank you.
no
Uh,
stone unturned, no
And no
ass
ass
unkicked.
unkicked. Yeah, I was
Yes.
hoping somebody would say it with me. Good. Thank you so much.
Bye,
And
Thank
everybody.
you very much.
Thank
for
you.
those of you with virgin ears, we do mean donkeys unkicked. So
Yes.
excuse that.
Bye-bye.
We love you from Doc
Bye.
Talk. Have a great night. Thanks,
Thank you,
everyone.
guys.
See you
All
next
right.
week.
Right
Thank
on.
you for everything. Make sure you read You Are Within the Norms and arachnoiditishope.com. And don't forget about Dr. Ibsen's GoFundMe. We are all supporting
Oh, yeah,
that. We
we
are
got
all
that
in
in there
support
too.
of him.
Oh,
Yes.
yeah.
Thank
Oh,
you
yeah.
all
We put
so
that
much.
in there. Don't forget that.
God bless us, everyone.
Bye-bye.
Thank you. Good night.